All right, so let's welcome Dr. Mrs. Olorunmotemi Oluwatosin. Please, ma, you have the floor, ma. Before, excuse me, but before she starts talking, I want to tell us that we can put our questions. If you have questions she's presenting on the chat box. All right, then as announced by Dr. Ilori, if you have you can put your name, your location, and the email address on the chat box. So if you have questions during the course of the presentation, please you can just put the question in the chat box and it will be read out and answered after the presentation. All right, you have the floor, ma. You're welcome, ma.
Thank you very much, Dr. Feniforo, for that introduction, and thank you everyone for having me. Good evening, everyone. If we are all in Nigeria, but in case there's somebody joining from outside the country, good day, depending on the time where you are. Thank you so much to the management of the CMDA Southwest webinar for this opportunity to speak to this distinguished audience. And I want to thank God for the privilege, for His grace upon our lives as a people of God, and for helping us to touch on very relevant issues that pertains to our life, our practice, and the society at large. Please, am I audible and clear?
Yes, ma'am.
Yes, ma, you are, ma.
Yeah, thank you. Thank you very much. So today we'll be talking on the current updates on childhood developmental disorders, a faith-based and family approach. We'll be talking about updates regarding the body, the care, and also the management, and how all of this pertains to us as people of God, as CMDA family. And we hope that at the end of all of these, we will have assignments that God will be provoking our hearts to look at as clinicians and as individuals in the various spaces that God has placed us. Thank you very much. I bring greetings from Ile-Ife and especially from the CMDA family there. I thank God for all that God has been helping us to do as a people, and I'm happy that quite a number of people are also here from the CMDA family in Ile-Ife. And I want to start by reading to us two quotes. This one from the Monitoring Child Development in the IMCS contest document. And it says, if child survival is one of the most important unfinished challenges that was bequeathed to us by the 20th century, then guaranteeing healthy growth and development for all children, a goal that has already been addressed in the 21st century, is key to meeting this challenge. Back then in medical school, we hear a lot about child survival strategies, and it went from growth monitoring to GOBI to GOBI FET and all. But for a long time, the emphasis on also ensuring the development of children, that they thrive and achieve their full potential, was not emphasized as it should be. But gradually, with many children surviving globally now, a lot of attention is being given to the fact that these children should not just survive, they should develop well. They should grow, yes. They should develop well and thrive and contribute to the society as they should. We also have this challenge that our Lord Jesus Christ gave unto us from Matthew 19:14. And let the little children come to me, and do not hinder them, for to such belongs the kingdom of heaven. Our Lord pointed out to us the very strategic place that children have in the kingdom. And there's nothing that we should allow to put a gap or a barrier between these children and God, not even developmental challenges or delays, which are very, very, which many times are preventable, which many times can help the child to be able to contribute his own quota to purpose and destiny and to fulfilling what he should in the kingdom of heaven. So I think even this is relevant to what we are going to be discussing today. I would be talking on this point. And I want to start by saying that child development, it's a continuous and dynamic process which entails how a child acquires and refines physical, cognitive, language, social, and emotional capacities from conception through early childhood. Oftentimes, we emphasize this between conception and up to 8 years, but some will extend this even to 18 years. And optimal development depends not only on biological growth, but also on supportive conditions such as good health, nutrition, safety, protection, responsive caregiving, and the likes. Many times in our society, the emphasis is on how the child is growing. You know, when a child is born, the mother is very keen to see that the baby is gaining weight, and they would want to know how well the baby is gaining weight. I guess most of us today are from Southwestern region. Traditionally in Yoruba language, you say "Shongbe," and then you start talking about Idagbasoke. But when we talk about Idagbasoke in Yoruba context, it seems to refer more to growth, as in that is the child increasing in height, is the child increasing in weight. But the aspects of how the child is able to evolve into the essential capabilities that are needed to be a very successful and impactful adult comes from how the child is able to develop across the various domains of development, whether physical, cognitive, language, or social emotional. And this also requires a lot of attention. And usually, the development is assessed across different domains. Gross motor that has to do with the use of the large muscles, fine motor domain that has to do with being able to do activities of daily living with the fine muscles of the hands, and also social adaptive or social emotional domain. Then language, which is the expressive and receptive cognition, as it were. As a child is developing, it's important to be able to talk about the importance, the significance of the early childhood period, which I mentioned earlier. Usually, a lot of brain development starts from conception. Even by the time the mother knows that she's pregnant, a lot has happened regarding neurulation. And then, as the child grows from birth, majority of the functions of the brain, like the sensory functions such as seeing and hearing, takes place in the first few months of life. In fact, the peak is usually within the first 1 year of life, the first 12 months. This period on this graph is the first 12 months up to this point. And we see that many of these functions peak even by 12 months. And by 24 months, even the higher cognitive functions have gotten to their peak. So a lot is expected to have happened even by 2 years. And gradually, up to 18 years, they may also be having synaptogenesis going on. But we see that if one misses the gap or the period of this early childhood development period, that's a very significant loss for the child. Another issue is the theory of neuroplasticity that talks about how malleable the brain is to interventions in this period. And that is why it's important that child development is done in a very intentional way, right from conception through early childhood and throughout the period of pediatric age group. Now, I want to quickly mention that the different components of what is required to be done for a child to optimize development has been well captured by this nurturing care framework for early childhood development, which was designed by the UNICEF together with WHO. And it talks about a number of factors that are needed. First is good health, and the other is adequate nutrition, responsive caregiving, safety and security, opportunities for early learning. Many times, yes, we look at good health. Is the child healthy? Is the child able to do the things that are expected for the child to do for age? And nutrition is also a very important part of the child's functioning. And then the responsive caregiving. How is this child being cared for such that the child is able to understand nurturing cues? Something as basic as cuddling an infant, speaking to the infant, saying words in the local dialects or even in other languages, but saying the right words that the child needs to understand can be so important for the caregiving. And then the issue of safety and security is very important. And this also has to do with how the child is made to understand who are the protective caregivers. In fact, trust is built so in a child within the first 12 months of life. As the child is beginning to see who is caring for the child and how much connection is developed, the child understands that I'm safe in this space. This is my family. These are the people that are raising me. And if things that are adverse are also exposed the child to at that time, it can also begin to affect the child's understanding of trust and security. Also, the opportunities for early learning. This is important and it's also something that should start from the home. All of these work together in ensuring that a child has a holistic development and a healthy start. The opportunities for early learning are greatly hampered when something goes wrong with the child's well-being across the various domains I've mentioned, whether it's gross motor or fine motor or cognition or social emotional. All of this can disrupt opportunities for early learning. And I'll explain this further when we're talking about various neurodevelopmental disorders. Now, I want to discuss on developmental disorders, which is our focus. Child developmental disorders are a group of conditions onset during the developmental period, but can extend typically before the age of 18. And they are characterized by deficits across the various domains, such that they can affect personal life, social life, even academic and occupational functioning as the child grows into an adult. There are different categories of developmental disorders, but the common one include autism spectrum disorders, attention deficit hyperactivity disorders, cerebral palsy, intellectual disabilities, and specific learning disabilities like dyslexia and the likes, stuttering, stammering, and the like. And these are the major categories according to DSM-5. And most of the time when we see this kind of children, we say they are children with special needs. That means they require some specific care and attention and accommodations because of the delays and disability they have suffered that can then affect their overall development and their ability to fit well into that nurturing care framework. So I've mentioned many of the conditions. I put cerebral palsy as the lead here because it ranks top on the list of developmental conditions in our country. Quite a number of children also have learning disability. There are some who have physical disability or are born with bad defects that also affect their development. And some have isolated sensory impairments like visual impairment, speech impairment, and even hearing impairment. Then the pervasive developmental disorders like autism and ADHD are quite prominent as well. And many of these children require special life care, special education, or an inclusive education with special consideration for their needs so that they can be optimal or awesome adults. What then is the global burden of developmental disorders? There's a lot that is being done again and again regarding the epidemiology of developmental disorders, but the population prevalence is up to 5%, with about 1 to 3 children having global developmental delay. And we say that the developmental delay is global when the child has delay in 2 or more domains out of the domains I've mentioned earlier. Among these, those who have intellectual disability ranks up to 1 to 3% with significant implications for life and for education. And it said that the lifetime cost supports an individual with intellectual disability is estimated to be approximately $1 million per person. That's huge. And that's why this is something we should be talking about largely in our society. And I'm happy that CMDA is also talking about this. I've mentioned that the global prevalence is more than 3%, and about 95% of these children live in lower middle-income countries. The highest burden in sub-Saharan Africa, and this burden has been increasing significantly in the last few years. And also, autism spectrum disorder prevalence and here ADHD has been increasing. And we see here that compared to high-income countries, in Africa, and especially sub-Saharan Africa, we contribute significantly to the age burden of developmental disorders. These areas in dark blue are the areas with high burden of developmental disorders. And this graph is talking about an age and as well as sex difference in children. And we see that yes, more of the children with these developmental disorders happen to be boys, and the age range. This graph is not covering the 0 to 3 years group, But as the children grow older, there seems to be more developmental delay, at least between the age of 3 to 7 age group to the school age. And this is probably because by the time they get into school, many of those who have been missed will then be identified. And then the group of conditions that are also neuroprogressive, where a child may have a good start and then gradually lose milestones and get worse, they also come to be identified. So we'll see a very high prevalence between 8 to 12 group and also the adolescent age group as well. Now, so globally, an estimated 200 million children under 5 fail to reach their potential in cognitive development because of some other factors like poverty, poor health, and nutrition. And I've tried to itemize some globally recognized factors that are contributing to developmental delay. In many high-income countries, prematurity is leading. Maturity also is a major contributing factor here as well, but probably not as prominent as in those developmental countries, where many preterms, even as early as 22 weeks, 24 weeks are being kept alive due to very improved care that is available in those high-income countries. Then there is also the risk of repeated infections, undernutrition, abuse and neglect. Some of them are also due to toxic exposures in the family setting and also poor maternal and family setting. And in Nigeria, what is the burden? There are a number of studies here and there, but many of the studies give a prevalence of about 1% in intentional studies. But many of these are not community-based studies. So we have many children, more than what we are capturing in the hospital, who have developmental disorders. And also, there are issues because the body in Nigeria is driven by survival of infants who previously might not have survived predator insults. We now have gradually improving neonatal care in many parts of the country. So we see children with beta asphyxia survive, children who are born premature survive. There's also a gradual increase in recognition of genetic conditions, which was not so before. Of course, I must say that there's still a long way to go when it comes to genetic conditions, and I will mention this later. Also, there are complexities with our health-seeking behavior, as many of these children will first be taken to traditional healers, prayer houses, patient medicine vendors, and they would only come with very late and also come with advanced comorbidities when a lot of harmful treatments have been instituted. So that affects the body. But the challenge for us is that we are having very late presentation and a huge burden as it were. And there is no systematic way of detecting these children early, especially in that period, 0 to 3 years, where the brain is plastic and they should be identified. And only 40% of Nigerian children are meeting the 2030 expected developmental norms. So many of our children, that's about half of our children. And if we have 100 children in school, we are saying about 50 of them are not given all that it takes for them to get the expected developmental norms. And the ones who are 0 to 3 are not even being monitored. So many of them who have delays or disabilities may be missed. What are the factors now in the environment? Beta asphyxia tops the list. And then we have severe neonatal jaundice, prematurity, low birth weight, certain nervous system infections like meningitis, encephalitis, and closely linked encephalopathies like cerebral malaria, poor nutrition, which is getting worse now with the current economic realities. And some of the children who have developmental conditions like cerebral palsy have superimposed undernutrition that worsens their outcome as well. So aside these specific risk factors that oftentimes predispose the children, there are other associated environmental risk factors like child abuse and neglect in many settings, poor family income that is closely linked with undernutrition. And if you take our mind back to that nurturing care framework that I showed us, you can see that these associated factors affect different parts of the nurturing care framework. Low maternal education will affect the mother's choices for nutrition, for promoting good health in our child, and eventually affect child development. Poor parenting practices, especially when we talk about responsive caregiving, that's very, very lacking in our setting. There are some cultural practices that even does not promote responding to a child's need, and the child is growing developmentally. In fact, most of the milestones are tailored towards the child development. For instance, when a child is understanding object permanence, that's the time when the child should learn through play. Should know that, when you're doing peekaboo, you're there, and they are using that to connect. But many times people don't even play with the children. I've had mothers come to the clinic and they say they don't have toy at home. Some now, with the advent of our phones, the screen is the toy. Quite a number of families. I don't know if there are people here who have similar experiences, but you see young children, 1 year old, 2 year old, coming into the clinic, and what they have with them is a phone. They will not even greet you. They just talk on the screen. And that screen addiction also is really affecting our children. I have to put pause sleep here because with what I've been doing on sleeping children, I've seen that we have a long way to go with understanding that sleep has a very significant contribution to development. In fact, it's been found that the optimal development of a child, especially in the first 6 months, has to do with how the child is able to achieve sleep consolidation. And nap in early childhood also is part of the processes that a child uses to have optimal development, and the changes that are meant to occur during that early childhood period are also related to sleep and sleep problem. That's why we see that many children who have developmental disorders like autism, ADHD, cerebral palsy, quite a number of them have poor sleep as well. And of course, birth spacing related issues. Now, I want to talk about the developmental disorders specifically. I would not give a discussion on each one, but I'll talk about them broadly and then focus majorly on how we identify, how we manage, and then quickly go to the family centered and state-based approaches that we should engage in. From all that we have said, we see that the occurrence of the developmental disorder is associated with a number of factors, some prenatal influences like congenital infections, and many of these can go unnoticed until the child is born, like congenital rubella, toxo, and in other parts of the world, Zika was quite prevalent at some point in Latin America and Asian countries. Some perinatal influence, especially the beta asphyxia, then postnatal infections and trauma. Genetic factors are beginning to really come also top on the list, as well as environmental exposures. In my practice, I've noticed that yes, there is an increasing occurrence of conditions like autism spectrum disorder, and in certain times I'll say that almost all the children, or let me say majority of these children who have autism spectrum disorder, may actually have underlying genetic predisposing factors, and some of them actually have dysmorphic features or some pointers to possible genetic etiology to their condition. Environmental exposure is also a very significant one, with the fact that a lot of environmental toxins are not regulated or measured. Lead levels are not measured routinely in our country, and we have lead exposures from different sources, from household items that are lead containing to environmental issues. And now, in many of our communities in Southwest, we are beginning to have illegal mining practices, and we don't know to what extent this is also affecting the exposures of our children to toxic items. I think last year or 2 years ago, we had concerns about even the plastic containers and the exposures to toxins that can affect the children. So in during diagnosis, the overview includes clinical history and examination and the appropriate tools that can be used to do intentional assessments of children for neurodevelopmental delay, and also the use of neuroimaging and genetic testing. All of these go hand in hand. Sometimes we should start majorly from taking the good clinical history and examination, but sometimes we do it and then come back again to look at what we have done and see how everything goes together. But it's important that in making diagnosis of whatever developmental disorder, one is guided by clinical assessment and seeing that what does the child have a significant delay at whatever age, and at whatever age, it means that there is no room for saying watchful waiting. Even when the child is a unit, there are things that we can do to check whether the child is fine And in the early infancy, there are intentional ways of screening the child for development. And one should really think about this. Many times, mothers who have children with developmental disease say, oh, they had noticed that something was wrong quite early, but I told somebody somewhere in my neighborhood, in church, I even came to the hospital and they said, oh, wait, your baby is still small. You can come back again. Let's give the baby some time. That is no longer the practice. There is a need for early and intentional screening of children for developmental delay. And the practicalities include that we want to identify, maybe this child has an identifiable treatable condition. An example is a child with hypothyroidism. That child should be identified early and treated even before we start seeing developmental delay. That brings before the role of newborn screening. And then some of them have prevalent serious conditions that require pre-diagnosis and also family-centered care. For instance, a child who has Duchenne muscular dystrophy. Recently I saw a young man who was above 20 and he had never had an objective evaluation for Duchenne muscular dystrophy, despite the fact that he was from a fairly educated family, but they had missed a lot of there were a lot of missed opportunities in assessment, even though the parents have done a lot to get in a diagnosis. So a lot can be missed if they're not focusing on some prevalent serious conditions. Yes, economic contributions are also very important. Some tests are expensive, some are not very difficult. Relative fragile air is not so cheap, but compared to so many other genetic tests, it's easier to do. And we have some people who are already working on this in country. And then, what are the practicalities of doing these investigations in young children and our heart in our own environment? So all of this has to be considered. But for us, as clinicians in this setting, it's very important that we do a good history and looking at identifiable risk factors, especially neonatal risk factors. And that in this, we have to work hand in hand with our neonatology colleagues. There are some babies that by the time we are discharging from neonatal, we know that all is not well with this baby. That child should not be just left to go home to determine whether all will be well or not. Sometimes we tell them that, oh, this child, your baby has had jaundice, it may not develop well. Your baby has had beta asphyxia, or baby was born premature, may not develop well. But how intentional are we in ensuring that this baby is helped early, especially in that period where the brain is plastic, in that 0 to 3 years, as I showed in the graph earlier? That is the time. So these babies in many other settings, and this is where we should be now in country, even in some other in South Africa and some other East African countries, what they do is to start a neonatal follow-up program. So the child is monitored right from discharge. It can be community-based, it can be home-based. Whether the child would then eventually develop cerebral palsy or other disabilities. And then some children will have gained the milestones, but they will regress. And when there's regression, it points to a significant developmental disorder. Sometimes it's something genetic, maybe autism spectrum disorder, it may be Rett syndrome, maybe some other genetic condition. So a regression should be picked quickly and also helped. Possible or definite seizures. Some children have very classic seizures. Some have seizures that may not be easily noticeable, that we call subtle seizures. Some have movement disorder. Any abnormal movement could also be pointed to a developmental disorder. And the muscle fatigue and the sensory impairments, which may be there before from birth or maybe occurring as a new onset condition. A cognitive decline or behavioral change. A child who has been doing well and just suddenly is not able to do things. Sometimes loss of previously attained speech milestones could be pointing to conditions like autism spectrum disorder. And then some other features, like when they have dysmorphic facial features. Consanguinity is not very prominent in the environment, but it's something to still be considered. And then there's a need to intentionally screen these children or to assess them for development. And that's how we can pick some of the things I've mentioned. For instance, if the child is regressing, the child may not be identified early until the regression has become very worse. But if there is a program to monitor the child, then the child can be picked early. So there are a number of tools like the Hammersmith Infant Neurologic Examination tool. Those are specific tool for assessing motor development. MDAT is Malawi Developmental Assessment. So there's also the global scales for early childhood development, Bailey scales. Those are some of the examples. And I've broken them down here. And some tools that seek developmental screening such that they will assess development globally across the various domains, while some would be very specific. These ones that I've listed are assessing development across various domains. There's some CP specific tools like the Hammersmith infant neurologic examination, and all of these will help us to do early detection of developmental disorders. And it's important that we do this for early intervention. I usually say that for children and for their brain, a stitch in time saves more than 9. It's very important that one does that early detection, because in that first 3 years of life, we can actually change the child's trajectory if intervention is started. Some of them could go back on track and become optimal in their development. And that also makes me to emphasize again the role of high-risk infant identification for every child who has a risk factor, either prenatal risk factor or perinatal risk factor. There should be specific developmental screening. This also includes us examining the child. This examination starts from the head-to-toe assessment when a newborn has been born. Recently, I went to see a colleague's child, and I realized that the baby, because of this strike, was not delivered in the hospital, but had not had hair circumference measured. Something as basic as hair circumference can tell a story. And we're doing a training also among primary healthcare workers to train to enhance their capacity in identifying developmental delays. And we realized that while they would measure weight for the children who are coming for immunization, hair circumference is not something that they monitor regularly. And it's important that we make that a practice. Checking the head and measuring their circumference can tell a story, can give us a baseline, because sometimes the children start well and then they regress. And also, it can give us an idea whether the child is small or big given at birth. Hearing assessment. Globally, there is a lot of advocacy for hearing screening, newborn hearing screening, early infancy hearing screening, preschool hearing screening. There is one of the global advocates for child development, Bola Olusoya. She mentions how she was missed as having hearing impairment in early childhood. Now she's a pediatrician and a leading one in campaigning for children with developmental disorders. Some children will have dysmorphic facies, they may have hearing or visual problems, they may have some skin lesions that might be pointing to a neurocutaneous condition, and also tone abnormalities like hypotonia, hypertonia. Some will have inborn errors of metabolism and be with organomegaly and spine defects, and all of this should be checked. And if any of these abnormalities are present, it points to the fact that the child needs further assessment. And this assessment includes checking specifically how the development is across the domain, what the child can do, what the child cannot do, using various tools. This is a diagram of the section of the MDAT, Malawi Developmental Assessment tool. There's the one that can be used in primary and secondary setting, and then this one is the MDAT IDEC. And if the child is assessed across domain and the child is failing 2 consecutive tasks, we refer for full assessment in a neurologist. And this one is a child development card that we are using here at the National Clinic to monitor children with developmental delay. And it has the MDAT, the most simplified one, the MDAT sign, and the Baton developmental screen. So that can be done in 5 minutes or less. Quickly screen children as they are being given immunization. But for those who need more specific assessment, a tool like AIN, that's the Hammersmith neurologic examination tool, can be used, and is very sensitive in identifying these children. Sometimes in high-income countries, it's recommended that it's done with MRI, but in our setting, we can use it alone. We can also look at children's movements. We call it general movements assessment, and we see whether they have fidgety movements or not that can, and there are norms for different age ranges. But aside all of these, sometimes the children will need other tests like genetic testing or blood tests as highlighted in this regard. These are different country-specific guidelines for this. We don't have such guidelines in our country. Some basic investigation like football can help in some settings. For instance, the child has macrocytic anemia. It can be due to some inborn errors of metabolism, even if they have vacuolated lymphocytes. But we don't often pay attention to this. Even as something as basic as thrombocytopenia in units can be telling a story. And their biochemical parameters, P and U, can be important. Lead, we are now measuring lead levels, and iron. These are very important biochemical tests that may be necessary. Some children will have persistently low calcium, and they may be having the Jaw syndrome. Quite a number of times, you see them presenting first to the cardiologist because the heart often shouts, but we miss those treatable conditions. Another treatable condition is hypothyroidism, like I mentioned earlier, and thyroid function test and screening is not something we are doing in our country. Some of them may have muscular dystrophies, and all they need is us doing creatinine kinase early, at least in our own setting where we can't do genetic diagnosis. This table just summarizes different forms of conditions and how that doing various tests can help to pick them early if one pays attention and has a high index of suspicion. And in addition to that, there's also a significant role of neuroimaging, and this is important for those who have cerebral palsy and even some of those with autism spectrum disorders. And sometimes those specific neurologic markers, some of them will have infarct because they have suffered perinatal stroke, and all of this can point to the need for early intervention in those children. Another important diagnostic technique is genetic testing. I'm happy Dr. Jalabi is on the call. Myself and her have been working together on these, and we found that this is a very important gap in our setting that we pray God will help us to address as children in this in our setting. A number of them have genetic condition. Recently, we've had families with 2 children who have, in fact, I had one, and this, I think, between last year and now, 4 children in the same family, and the 4 of them have a genetic condition causing developmental disorder. So sometimes for that family is a huge burden, and we need a lot of help to be able to have this test done. Yes, in our hospital here we do karyotyping. I know a colleague in the East who is doing SDNA testing, but the others like whole exome and whole genome sequencing are not outside our reach with the help of our God. And also there's the role of metabolic workup, testing these children for different inborn errors of metabolism. We also need guidelines. I'm just showing us these guidelines so that we know that guidelines exist, but we don't have country-specific guidelines. This is the American guideline, and we also have the UK guideline, Canadian guideline, but we also need to develop our own country-specific guideline in managing these children. So I'll be rounding up now. I know my time is nearly up to talk about management and our role as clinicians in having a faith-based and family-centered approach to the management of these children. It's about teamwork, teaming around the child. Managing developmental disorder is not for one person's role. It's not even just a neurologist's role. Here in our hospital, we have a multidisciplinary team, and we do the joint assessment for these children and plan the care of the child together with the family. And then we have to coordinate with other important stakeholders like the education team and the community as well. And that's where our role as faith-based community is also coming. So in early intervention, the multidisciplinary team is so important, and it includes everybody. The therapists, the occupational therapists work together with us as neurologists, and then also the speech therapists, dietitians, and social workers. They are all important people. Then the parents, these are very important people. Baby Ubuntu program, which we run here, is an example of such parent-centered, family-centered approach, where we coach the parents to understand that goals and to embrace the care of the children, and then to help them to identify comorbidities, which can be an overlap of autism and ADHD, sleep disorders, which cause across many of these conditions. Sometimes they have psychiatric comorbidities. So working with adolescent mental health clinicians is also very important. Identifying what is affecting functions also is required, and these are different models for assessing motor function, manual ability, communication function, eating and drinking, visual function, because all of this can limit the quality of life of the child. This is just showing us the different gross motor category and how much support the child needs depending on where the child falls. But taking care of the family is so important. And this has to do with our role as parents and caregivers. And here, the intervention is not just for children who have developmental delays, but all children. We all have children that are connected to us, either biologically or children that you see in church or in the neighborhood. What are the things we are doing to support the development of these children using the nurturing care framework that I showed us earlier? It's important that we ensure that family-centered care is what we do, and it involves partnering with the families as healthcare professionals so that the child's care is holistic. The child and the family are involved in decision making. Usually, when we are going to do the MDT assessments, we do joint goal setting with the parents, and that's very important. And these are some pictures from some of the parent intervention programs, like the Baby Ubuntu program that we are running here. And we also celebrate the children through community sensitization. This is a World Cerebral Palsy Day celebration for the children here. This one was during International Day for People with Disabilities. So that the children, some of them are they're kept at home, locked at home. So they need to be helped to come out. And in managing these children, our role are diverse. Even detecting that they have the developmental delay on time is one of the very major roles. Referring them appropriately to specialists and also looking for other secondary comorbidities is our role. Liaising with education is a very important role to ensure that these children are held in the school. And many of them don't even get a good placement in school, or the kind of school structure is not enhancing for them. And I tell you, this issue with these children development is supported as across various places. I know quite a number of colleagues who have children who have developmental disorders, and these challenges are being experienced across different states. So supporting the holistic development of every child is part of our role, ensuring that the responsive caregiving is something that parents learn. The WHO and UNICEF, they have a program called Care for Child Development, and a number of apps that parents can latch onto to learn about how to care for the child responsibly through play, through toys, through communicating with the child at age-appropriate words, not giving them phones and phones and phones rather than connection. And also, there are a lot of digital and emerging technologies that can promote the child's health. And also, our role comes in play in addressing challenges and late diagnosis, removing the health system barriers. Some of us are involved in administration, and also building the capacity of our health system to address biomarkers like inborn errors of metabolism screening and genetic screening is something we can do in country. Many neighboring African countries are already doing this. And I would round up by atomizing our faith-based approach and some suggestions that I have, that any of us in our churches have children church program, but is there a special needs section? Are we inclusive in what we are exposing the children to? One of the parents told me in clinic that I left a particular church because of the way my child was addressed, because they have special needs. He has autism spectrum disorder. All of this has to do with how we connect and how we even train the workers in the children church section. Parent support groups. We can have and support parents through parent support groups in our various spaces. We can hold health education seminars in our churches for the development of every child, and specifically those who have developmental disability. We can offer respite care. There are some Catholic-based missions that are doing this very well, and other missions and churches should buy into this idea. Financial assistance funds, quite a number of churches are doing this, but we can do better. And as individuals, we can. Advocacy and awareness campaigns, we can do a lot to counter stigma. We had International Day of Disability last week. What are we doing? Having accessible worship spaces. This is something we addressed a lot last week during International Day of People with Disabilities. And many of our churches have access. Some of our churches are in story buildings, or even those that are not in story buildings, they don't have disability access. If you have a child who has to come with wheelchair, how would the child be able to worship? One mother she's a professor, but she said her child had autism. She had to stay at the car park with the child because she can't stay in the church because of accessibility and safety that is not available in our worship spaces. We need to join the advocates against stigma in every space, in line with what our Lord said in Matthew 25:40, that if you have done any of these things to any of the least of these children, you have done it to me. So we can offer service to the families and the children by ensuring that no child is left out. Remember the message from Matthew 19:14 on inclusion. Let the little children come to me and not hinder them, for to such belongs the kingdom of heaven. So in conclusion, a lot of emphasis on developmental monitoring has been made in this presentation. I hope that we'll all be advocates in our various spaces. And it's also important to pay attention to nurturing, caregiving, and early detection of developmental disorders. Don't let the phone be the nanny for your child. And you can also encourage other mothers to learn to parent intentionally those children, and need for family-centered approach in the care of the children. You have to carry the family along. Sometimes what is priority to us, not what's priority to them, and we all have to be on the same page as we team around the child, such that every child should be given the best opportunity, not just to survive, but to thrive. Thank you very much.
Thank you so much, Ma. That was a wonderful presentation. All right, thank you so much, Ma. We are very sure we learned a lot from this presentation. All right, so we can put our questions on the chat box. What we do that, I just want to say is you said no, in terms of the presentation sheet on the definition of childhood development, and I talk about that diagram. I really love that diagram of nurturing care frame of the early developmental development, about the frame about good health, adequate nutrition, responsive caregiving, safety and security, then opportunity for early learning. And she really mentioned that a simple task as a simple thing like coding or speaking to the infants, really very important. So, and then they should talk about the global burden of the early development and child development which is over 2 million. That's huge. All right. She talk about the risk factors, the various factors. All right, and the things we should note that poor parenting practices is one of the reasons, part of the aspect factors of having issues like this. All right, so she talked about us reducing screen addiction. I see that's common now, reducing screen addiction, then and to help our children have good sleep, because poor sleep is associated with all these developmental issues. We talk about the diagnosis, the clinical features, about the different clinical tools to diagnose these people, and also for us neonatologists to refer patients early when you're suspecting patients having issue on your ward. Patient has and neonatologists better, so you refer on time to the neurologist for proper evaluation. All right, she talked about a lot of things, the family center, how we should support children holistically, and how to help as physicians to remove the health system barrier, so that when we are seeing children, maybe in church, even our church, anywhere to refer them, then about the different faith-based approach. So thank you so much, Ma, for the insightful and lucid presentation. I don't know if you have any question, kindly drop it on the chat box so that I can read it out to her. All right, okay. I think I can see only one question here, or you can signify by raising up your electronic hand so that you be called and you can ask the question. All right, so let me start with the question on the chat box. The first question is please, can you hear me? Am I audible?
Yes, ma'am.
All right, thank you, sir. All right, so the first question is that Dr. Olorunmotemi said, you mentioned that only 40% of Nigerian children are meeting up with early childhood developmental norms. That is a shocking figure. That's up to 50%. Yeah, almost half, yes. But what are these developmental norms exactly? Are they the developmental milestones? That's the first question. Then there's another question here. Okay, the second question, all right, from the same person, she said that following brain insults in perinatal and early childhood, if developmental reverses or delay begins to appear, and this is caught early, is it possible? Is this still possibly reversible? The speaker seems to suggest that it is. All right, so okay, there's another question. And that speaker is a very interesting lecture, ma'am. Thank you. Please recommend a tool for neurological assessment from birth for use by primary care doctors. Also, is there any advancement or hope for stem cell treatment of this condition? All right. Then the last question here. There's a question, you said that for a child that is not up to 2 months of age and the weight is the same as the birth weight, could that be a sign of developmental issue? All right, man, those are the 3 questions we have as at now. I don't know if you can respond to that, ma. Hello, ma. Can you hear me?
Hello. Okay, I can hear you. Thank you. Am I audible, please?
Yes,
Can you
ma.
hear me? Okay, thank you very much.
Yes,
I'll
ma.
try to get to be seeing my chat so that I can just pick each of the questions. Okay, I'll start from the base. For a child that is not up to 2 months of age and weighs the same as birth weight, could this be a sign of developmental issue? It's possible. It may be a sign of just a growth issue where we say the child is failing to thrive. That means the child is not gaining weight, and that may be from an isolated growth condition. For instance, if a child has a congenital heart disease, they may not be gaining weight. It may not necessarily be a developmental issue, but it's also possible that that growth delay is linked to developmental delay. In fact, many times when the cardiologist in our unit call me to see a child, either because he has a congenital disease and is having seizures, I realized that quite a number of them have a very typical fascia or some pointers to a global developmental delay. And in such instance, it may just be that the heart condition is just one out of many other issues. For instance, the child who has congenital rubella, there was one who had PDA closure and then had hearing impairment, and because of that, we saw a neurology clinic. I'm like, okay, this is actually congenital rubella. There are some who are having recurrent infections and also have congenital disease, and because of that, they are not thriving, but they also have developmental delay. They have something like the Jones syndrome. So when there is one pointer, it's important to check for other issues. So let me say conclusion in answering that question is that when a child is not gaining weight, the child should have a holistic assessment, including a developmental assessment, especially developmental assessment, because it could be a pointer to developmental issue, although it may not always be. Thank you, Mark. Then concerning the issue of children meeting developmental norms, yes, the shocking figure, and I will explain why that figure is that alarming. It's not just about milestones. The indicator for early childhood development globally that is used by WHO and UNICEF is the nurturing care framework. And if you look at nurturing care framework, it cuts across different spaces. So they're looking at how many children are achieving their milestones. Yes, that percentage may not be as much as 48%, but it will shock you that it's still very huge. I don't have it right now on my fingertips, but yes. And the reason why I can't talk about a national figure for that is that we don't even have a national capturing system for generating data about milestones, about how many children are reaching their milestones at specific timelines, because we're not monitoring nationally. And a number of children may have mild delay which may still affect their potential. So when they are talking about developmental norms, they are looking at the child holistically using the nurturing care framework. And it includes how many children are exposed to responsive caregiving through some parental evaluations, how many children are growing up in safe families, not just areas where there's terrorism. How many of children in their own family are not experiencing parental violence, family violence, wrong parenting practices, wrong let me say punishment now, practices as it were, and abuse. Then there's also the issue of nutrition, there's also the issue of good health, and there's also the issue of early opportunities for early learning. So this early childhood developmental norms cuts across all the components of the framework, not just monitoring of developmental milestones, which is captured under good health. So that's how that developmental norm. So if we look at it across board, we'll see that a lot of issues are happening. If a child is at home and in school, he has spent all day with the teachers and then comes home, he's not able to connect with the parents, he's at the toys in the corner, the parents are all busy, the child is left with a nanny or left with the TV or may not even be seeing the one. That's not responsive caregiving. And to shock how many Nigerian parents are being raised like that. So that is part of the contributors to that shocking figure. Now, to the second side of your question, Dr. Osakwade, is regarding brain insults in perinatal or early childhood. If development regress or delay begins to appear, and this is quarterly, is it still possibly reversible? Yes, depending on the kind of brain insult and the extent of the brain insult and the part of the brain that is involved. I must say that the brain of children forgives. I've seen children who we have managed for infections, especially when it is cerebral malaria or encephalitis, recover wonderfully well. Sometimes you would wonder if this child would ever be able to regain this function. I still saw one, I think last month. I couldn't even recognize the child again. They had to tell me it was the one, the way he recovered. So yes, depending on what has caused the insult, some of them will recover well. But even those who have the very severe insult, like very severe beta-asphyxia with HIE stage 2, stage 3, if the data available globally shows that if they are picked early and the intervention is intentional right from the neonatal care to the immediate early infant period, the eventual outcome may not be as severe as what it will have been when they are left on their home. And some of them will go home, they'll start having seizures, nobody knows, or the parents may not even identify that those are seizures like infantile spasms and they are not treated. So all of these further worsen the previous insult that the child has had and further worsen the outcome. Yes, it's possible that there might be some that would have conditions that are not easily reversible, like those who have genetic conditions. There are some that are not treatable. You remember when I mentioned considerations for diagnosis, you have to identify which one is treatable, which one is not. But sincerely, when we are doing intentional developmental screening, we are able to pick some who have mild delay that will be easily helped by the interventions to get on track. For instance, some children who have an hemiplegic cerebral palsy, if they are picked early, you might be able to help them to gain function. In the other hand, if early intervention is given. So some of them will go back to the appropriate developmental trajectory. So like when we are drawing their graph, they can go back to the right graph. There are some who have hearing impairment. Because of that, they have speech delay. But when there's no hearing screening, they will not be able to gain speech at the appropriate time. But if that hearing is assessed and checked, they'll be able to gain speech and they'll be able to go back on track. Some children have visual impairment. There's a time when visual impairment, if treated, maybe they have congenital cataract, they would be able to have their retina stimulated. But if you miss that time, it might affect the eventual outcome, even if you pick them later. For children with CP, it's even worse. By the time they are coming at age 5, 6, 7 with contractions, there's little you can do. You send for physiotherapy, but you're just not getting anywhere. So I have seen a lot of changes with early intervention, and I can say yes, it can actually make a lot of difference. May not be every child, but the percentage is quite encouraging. If early intervention is commenced. Okay, and I think there's still one more question. Yes, regarding a tool for neurological assessment from birth for use for primary care doctors. This is a big one in the sense that there are tools, but how many of those tools are accessible to primary care doctors? I can talk about what is available in my practice and then talk about where we should be nationally. Uh, in our practice, we use the simplified MDAT tool as well as the tool that was developed by Professor Lagunjo in Ibadan also, Ibadan Developmental Screening Tool. And the IBDS can be used by parents to quickly go through and say what they think about their child because it's just specific questions. And similar to the ages and stages that are used in many countries like the UK. And there's also that ease of assessment. And it was that ease that made us actually use the MDAT sign, which is focused on the what the child can do for some specific questions that are very simple, even from the primary care doctors and primary care health workers to identify. Here we work with the choose and we give them posters, forms, charts that tells which one question or one sign they should look for to tell whether a child is not developing well in gross motor, fine motor, social and cognitive domain. And there are things they can check from 0 to 3 months. We aligned what they could check with the current national program on immunization. 0 to 3 months, what they can check. Sorry, I meant 0 to 6 weeks, and then what they can check at 10 weeks, at 14 weeks, 6 months, 9 months, 12 months, 15 months, like that. And we also highlighted some features of disability, like checking the head of the child, or measuring the head circumference, looking at the eyes, is there strabismus, can the child track light, and all of that. So all of that is captured in this MDAT sign tool, which requires minimal training, but yes, with that minimal training, people can do it. There's a global scale for early child development. That's a WHO tool that is being developed to be used globally, but that requires training. So it might not be that accessible to primary care doctors. But I tell you, the Ibadan tool is accessible. The MDAT sign tool is also accessible, and we can connect to support children to be able to identify these children. What is required now is that these ones I've mentioned are just screening tools. If the child has concern based on this screening tools, the child needs to be referred to a specialist for more detailed assessment before we can label the child as having a diagnosis. And from the health workers we have trained, sincerely, when they send patients as having concern, our rate of having confirmed diagnosis is as much as 95%. So many times the children actually do have concern when they are filling those screening tools. So it's available. Now, what we need nationally is to be speaking the same language. And that's where we need to advocate more for a unified tool where every child all across the nation can be screened and also helped to get a good referral to a specialist. Regarding advancements in stem cell treatment, I'll say yes, a lot is being done when it comes to stem cell treatment. I carefully avoided mentioning it because many of the supposed stem cell therapy have not been approved by the many regulatory societies. I remember speaking to a colleague who practices in the UK, and she was saying that even in UK, parents would leave the UK and go to some Asian countries because they want stem cell intervention for autism, for cerebral palsy. But at the end of the day, it's not all success stories. So you see that in many high-income countries, specifically US, Australia, UK, stem cell transplant is not yet exactly in the guideline, but quite a number of trials are ongoing, and we hope that this may be helpful. However, some children may have specific genetic conditions, and there are gene therapies that are available. For instance, for spinal muscular atrophy, since about 2016, there's been Spinraza and a lot of other gene therapies that are evolving. And there are children in country who have SME, that's spinal muscular atrophy. For teaching, there are gene therapies. So there are quite a number of gene therapy condition interventions, gene therapeutic interventions that are evolving. But we need to even first be able to make a genetic diagnosis before we can be able to give gene therapy. Because for many of the conditions where gene therapies are available, there are specific genetic indicators that can then say, okay, this one will benefit for gene therapy. And those are some of the issues that need to be addressed before we can get to that point. Thank you very much.
Thank you very much, Ma. There's still one more question, Ma, from Professor Eson. That's from faith perspective, how do you handle breaking the news of the possible outcome of the condition to the family and still reassure them to hope against hope, especially for those who will not likely live an independent life?
Thank you very much, sir. That's
Hello.
very, very important question. Hello, can you hear me, ma'am?
Yes, ma. Yes, ma.
Hello, can you hear me? Okay.
Yes,
I
ma.
was saying that that's a very important question, and I'm happy that it's coming up because that's the reality. Some of these conditions may not improve. And this ranges from those who have very severe cerebral palsy with severe functional impairments to those who have a neurodegenerative condition, which may be genetic. And sometimes you do genetic testing, and the reality before you is that this child is not doing well, or even from MRI, or even from clinical assessment. Some who are coming at a time when you know that even at this stage, the child will probably not work. And some parents would come with very, very great expectations. They feel that, okay, now we are here, we have a diagnosis. Please, can this child work? We want this child to go to school. We want this child to do well in school. We want this child to perform like his other mates. And sometimes this is an only child in a family, so it can really be overwhelming. And I think that's another area where our role as clinicians, as Christian clinician, comes in. Letting people see God even in the midst of the most difficult situation. It's sometimes very tough because we have to come face to face with talking with the families that, yes, this is a challenge, and this child this is what the pattern of this child's life can be like. We are not God, we won't claim God, but we have to help them to understand what this all involves. And I will use two examples to show this. I once saw a woman, then I was doing observership in the US, and they had a genetic counseling session. This child has a diagnosis of a condition that was non-treatable. But when the genetic counseling session was done, the parents were so cheerful. They were appreciating everybody on the team, and they were saying, oh, now we are relieved. Now we understand what is going wrong with our child. We are so grateful that we have the understanding. I was like, wow. But it took them a journey. But the fact that eventually they had a diagnosis gave them some form of respite. That's okay, this is not caused by us, this is not caused by a mistake we made. So sometimes our role is helping them understand to the best of our knowledge and what signs are made available to us. This is what we think has caused it. Sometimes it is not their mistake. Sometimes it's their mistake, but if we help them to see that, oh yes, you didn't know that this is not something that you should do and all of that, then it might help them to be able to live with the reality. Because some parents don't even forgive themselves and they live with that burden for life. Some they don't even understand the diagnosis. So our role is to take them through the journey, which requires a lot of patience. In my practice, sometimes you just have to allow them to cry. Sometimes you have to be there as a responsive person when they want to ask questions and say, okay, are you sure this is what is going on? Are you saying that this child will not be able to do these things? So it's not a one-day thing, but it requires being very responsive as a clinician and as a caregiver, and being very supportive, understanding where they are coming from, seeing things through their own eyes, and being able to walk the journey with them. I must tell you, it's a calling, it's a ministry. It's not just about giving care. Sometimes you might be with a family for 1 hour and you have a long clinic with every patient load. So you have to really be there to hear them out. And if you think, oh, a regular clinic time would not be able to do it, you might have to schedule a time. You might have to work with a team of trained counselors or clinical psychologists if you have that resource in your facility. I know not every facility has that. And ideally, we should work with the pastors and the spiritual authorities that the parents also believe in. That's one area that we are lacking. Somebody was asking me today that do we have pastors and intercessors on our MDT, and I'm glad that they are there. But in reality, we are not doing well enough in that regard. Ideally, in doing the counseling, taking them through the journey of diagnosis, we should bring the faith-based organizations and all along so that they can also support them at home. Especially here that we don't have social workers who will go home to the child. The other example I have is that of another woman who had a 20. At that time, I think her child was 21, and this was also in another country. This child has severe cerebral palsy, no neck control, wheelchair bound, was having respiratory issues, I think, and had to go home on oxygen supplementation. And the mother was so cheerful, and she said, "Oh, I'm grateful for this child. It's one I've got." And I asked her that, "Have you considered having another child?" She said, "Oh, it's enough for me." Yes, I know that in that setting, the support system made a lot of difference. And I think that's where we as clinicians who are faith-based people also come along. How can we in our own space, in our institution, begin to provide more support? I know Professor Eson usually talks about how we can support these families to have a school in our facilities or in our environment where the children can be accepted and cared for. Because some parents, they will not even be able to work again because they have a child. So the burden of care is so huge in our setting that by the time they know that this is the reality, it's difficult for them to cope with. And that's where we can all advocate for the child. But yes, bringing hope, as Professor Son asked, requires first letting them understand what this is all about, letting them connect with a team. We see that a lot in our parent support group, in the Baby Booster program. By the time all the mothers come and talk about their experience, they say, "Oh, okay, it's true. This also happened. This also happened." So it helps them to understand the journey. Seeing those who have gone ahead also helps them. So sometimes when I've done all the talking, I have to bring other experienced caregivers to help support the new families and the new mothers, because that may help them to actually be able to get some hope and get some support. And of course, connecting with a church family. And I think this connection with church family requires us training church members too, because sometimes the problems even come from churches. And I don't know how best to say that. Last week when we were having the International Day for People with Disability, one of our colleagues who spoke talked about how that in church programs, when the child goes, when each person with disability goes there, people are saying, "We are pray for the child, pray for the child, pray for the child." While that is not wrong, honestly, it's not wrong to pray, and I believe, and I know we all believe that God does miracles, but we are not the one to determine who God would make to walk from a wheelchair and who God will give the grace to go through and still be wheelchair bound. But sometimes the understanding in the church setting is not correct. I remember that last week there was a lady who spoke from the UK who used to be here in the country, and she talked that even in the UK, she can't take her child to the Nigerian church there. She had to be going to a white church because colleagues there did not seem to still understand the care for the child, and there are a lot of expectations. Another person said a child was called out in a church program and they started praying, and because of that, he stopped going to that church. it's not wrong to pray. I hope you understand that. That is not, I'm not saying that it's wrong to pray. But when we make the people a spectacle and they become a point of embarrassment because their child has a special need, then we're not giving them hope. And that's why I think that even in our church setting, we need to train people. We need to train children church workers. We need to train other parents. One parent told me that in church, another mother just pulled her own child away from a child with special needs. And we're passing wrong messages that way. So I hope that with that I've addressed all the questions.
Yes, ma. Thank you so much, ma, for the presentation. Dr. Oduyemi just commented there that he thinks that they can be managed, these children can be managed in collaboration with pediatric dentists and developmental psychologists. And he said, thank
Absolutely.
you for the presentation.
Yes, they are part of our team too. We have a dentist on the team of two of them too. So yes, absolutely correct, sir.
Thank you so much, ma, for the lucid, insightful presentation. People are appreciating you on the page. We really appreciate the presentation, ma. All right. Before we close the webinar, I want to call on Dr. Anag Ngalato. I hope I'm able to pronounce the name well. So, yeah, he's a excuse me, is a professional professional developmental development director in CMDA Nigeria. All right, so sir, I want to welcome you and say thank you for staying with us on this webinar. And please kindly introduce the CMDA leadership, sir, on the call. Thank you very much, sir.
Well, all right. Thank you very much. Thank you very much, everyone. And thank you so very much to our facilitator for today. We're very grateful, Ma, for this very insightful presentation. Want to appreciate everyone on the call, the leadership of the House, most especially I see our former past CMDA VP West, Professor Esson. Thank you so much for being on the call too, sir, and every other both chapter chair and leadership across the CMDA Western Zone. Thank you also our CPD coordinator for the West and the facilitator of the meeting for today. Thank you. God bless us all. Amen.
Amen. Thank you so much, sir. I think Professor S wants to say something. You have the floor, sir.
Yes, sir. Thank you. I want to greet our teacher, Professor Peter Light, on the immediate past at CMD of University Teaching Hospital, Oshobo. You're welcome, sir. Thank you very much for joining us, sir.
Thank you so much for that, sir. All right, I want to once again thank the speaker for the lucid presentation. I want to thank everybody that came for the presentation. At a point, we were up to 53. Thank you so much for coming for the presentation. Dr. Ilori, over to you. Is there any other announcements, sir?
So once again, I want to appreciate everyone for making it tonight. So I think we have any of our elders to kindly give us a closing prayer. So I want to humbly invite Dr. Amos Okedari to close us in prayers. Thank you, sir. Dr. Amos Okedari, sir, please help us with the closing prayer, sir.
Once again, we appreciate all our people that have shown up at this meeting. We especially appreciate our facilitator for giving us such an in-depth training, I will call it. And we are praying that this wisdom we have acquired, God will help us to be able to use it in the different places where the Lord will plant us. Shall we pray? Our dear Lord God Almighty, we are so grateful for the grace you have given us to come together this evening. Thank you especially for life and well-being. And we thank you for how you made the planning as well as the execution of this program to be successful. We want to thank you for the great knowledge and great insight that you are giving us, especially in the area of care of those children that may have developmental delay. We are praying, Father, that you continue to give us all the opportunity and the grace to be able to help them, not only the children, but even their family. And we are trusting you that even within our scope of work and ministry, miraculous will not elude us. And as we interact with these people, both the family and the children, you will touch them and you make their life to be fulfilled. Once again, we want to pray and appreciate the grace you are giving us to go through this year up to this time. As we conclude the year and move into a new year, we are trusting you that you will sustain the work and ministry of the CMDA, not only across the Southwest, but across the nation and across the world. Thank you.